Good evening. I am Dr. Jeffrey Sterling, Surgeon General for Alpha Phi Alpha Fraternity Incorporated, and on behalf of our General President, Brother Willis Lonzer III, we want to welcome you to another edition of the Surgeon General Initiative webinar series. It was back in 1980 when Alpha Phi Alpha and the March of Dimes began collaborating on our Project Alpha, which provides young men with current and accurate information about teen pregnancy prevention and other health considerations. In that spirit, we are just thrilled tonight to be hosting this webinar with members from the representatives from the March of Dimes. As you know, also, we are always interested in healthcare disparities, and tonight is no different. The preterm birth rate in 2021 was noted to be 10.5%, although in African Americans, that rate is 14.8%, some 50% higher. We're going to talk about why that is and what you can do to be empowered to ensure that you or your family members having kids not only have a reduced rate, the best possible chance of having a reduced rate, but from the types of birth defects that also suffer from healthcare disparities. With that in mind, we've assembled, we say this every week and is always true, but it's especially true this week. We've assembled a group of healthcare heroes in various fashions today. And to bring them in, we welcome back tonight, as tonight's moderator, Alpha Phi Alpha's Deputy Surgeon General for Family Health. Brother Dr. Victor Narcisse III is a spring 1990 initiate of the Rho Iota chapter of Alpha Phi Alpha, and he's currently active in Alpha Eta Lambda chapter. He practices at the Houston Methodist Hospital as the Associate Division Head of Hospital Medicine, and he is the Director of Clinical Research in the Division of Hospital Medicine. Dr. Narcisse is board certified in internal medicine and geriatric medicine, and he is a fellow of the American College of Physicians and the Society of Hospital Medicine. Have a great show, and let's empower the masses. Be well.
Good evening. Tonight we have a robust group of individuals to talk about health outcomes in a way that we don't often. And as a geriatrician, I often see patients at the other end of their lives. But today we're going to talk about a unique set of issues. And today we're going to bring forth a number of individuals. First, Shireen Simon. Simon is the Senior Director of Health Equity at the March of Dimes. She has a MPH in epidemiology and health education and has spent the last 15 years leading large-scale domestic global initiatives for under-resourced communities. Thank you so much. Brother James Kelly is a member of Upsilon Lambda in Jacksonville, and he spent a lot of his career with the U.S. Department of Transportation and pipeline safety, but has spent a tremendous amount of time, energy, and effort as project manager of the Project Alpha National Committee, and he, as a result, a committee member that has focused a great deal on prematurity. Thank you, Brother Kelly. I'd also like to bring forth Mecca and Brother Mukhtar Rakib. They're proud parents of 4 children, twin boys that were born at 23 weeks. They've been March of Dimes family ambassadors since 2020. Ms. Mecca has served on the Parent Advisory Council in the NICU at the Children's National Hospital since 2018. And Brother Mukhtar has been a member of Alpha Alpha since 2006. Since the birth of their twin boys, they have participated in a number of community service initiatives surrounding the advocacy and awareness of premature births. So we'd like to thank them. Coming back to discuss issues as Brother Gonzalo Rodriguez, MD, FACOG, as a fellow of the American College of Obstetrics
Good evening to all. So it seems like we're having a little technical difficulties with Dr. Narcisse, but I'm sure he will be back online shortly. And so this evening, as we assemble here today to really talk about this serious issue of preterm birth and other issues that we're facing, tonight we really want to focus on also the gap that we see in our African American communities. As it was mentioned, the report card that's put out annually by the March of Dimes really shows that there's not only a disparity in the United States, but there is a disparity, particularly in the African American community. So tonight we really want to discuss those issues and talk about those things. So I would ask, as we get into this conversation, let's first really understand what is preterm birth, what is prematurity. And I think Dr. Rodriguez, if you could please, for our listening audience, kind of cover that question for us.
Yes, sir. Thank you. And I really appreciate being part of this distinguished panel. This evening, I want to give you an overview. Both my parents were teachers, so it's a blessing and a curse. I would like you to be able to understand that when a person is pregnant, a full-term gestation is 40 weeks. We feel that a baby is considered preterm if they are delivered for whatever reason less than 3 weeks prior to that due date. 37 weeks is the cutoff. In medical terminology, we find that that is a preterm, any baby that's born less than 37 weeks. The reason we say that is that we find that babies, there are systems that need to mature, and the best incubator for that maturity is within the womb of the mother. And by multiple factors can cause a person to either be delivered because of the life of the mother is endangered, or there can be what's called preterm labor problems that can eventually have that infant be born. There is no question that when we think about preterm and premature deliveries, the overall and this day is so significant because it's considered World Prematurity Day, and we have many heroes and many technical advances that has allowed for the cusp of life, the cusp of viability, the ability of an infant to be alive has been, dramatically improved over the years. When I was a resident, we found that, approximately 10% of those babies that were born after 24 weeks, let's say, 1 pound, we find that those infants maybe had a 10% chance. But now, approximately 70% of those infants will be able to survive. The earlier the gestation of prematurity, the more complications can arise while we are trying to support that infant to be able to go home with their parents. And we find that 50% of those babies will have mild disabilities, but the earlier the gestation, the incidence of having moderate to high disabilities has increased. But we are trying our best to improve that and those numbers and that statistics. When I start out and I talk to my residents and I talk about the anatomy and physiology of the uterus is where the pregnancy has had implantation and a chance to grow. The implantation of the fertilized egg implants within the uterus. There is a connection there with the placenta, and then you have amniotic fluid. Individual is being established, and that baby will start to grow. That's when we start thinking about what types of things is going to, what kind of environment can be deleterious, or what kind of environment is going to cause that person to go into labor. Well, there are infectious causes. There can be anatomic problems within the uterine wall, and there can be a number of traumatic experiences that can occur. But we have found that despite all of these other external factors, we have found that there is a psychological and stress factors that have increased dramatically the incidence of preterm deliveries. So I'd like to be able to give you that as an overview to start our conversation, to realize that if we are not looking at the common denominators and looking at the disparities and looking at why things happen, how can we make a difference? So I'd like to be able to, at this time, be able to give you that overview to start off.
Brother Rodriguez, what type of testing would you recommend someone to undergo to evaluate how their pregnancy is going?
Currently, the obstetrics and gynecology, most patients will get at least one ultrasound during their pregnancy. It's called an anatomic survey. And that occurs between 16 and 20 weeks into the gestation. There is no question that at that time, you can see some of whether the bladder is in the right place, whether the heart is in the right place, whether the location anatomically is in the right place. However, it has nothing to do about maturity. And that is the reason why there's been a push to be able to, at the first visit, document the date and age of your pregnancy to be able to make conscious and medical decisions each step along the way. We find that if you don't know accurate dating, then you are guessing in terms of the exposure of that baby at each step along the way. So at our unit, when a person comes in, unfortunately, in the different places I've practiced in the United States, we find that pregnancy is not something that has been planned. A person comes in, if we could ideally have pre-pregnancy planning, we would be far ahead of knowing what that person's pre-pregnancy state, medical state is, and come forward, as opposed to being pregnant already and having to try to work backwards to try to determine what is going on.
Can you tell us a little bit about the factors that seem to increase the risk of premature births?
Okay, some of the factors, the number one is if you've had a previous preterm birth, you try to individualize each patient that comes through the door. I have found that having a conversation about that person's family, if they've had an older sister that's had a preterm delivery, or if their mother has had a series of preterm deliveries, all of these raises the level of concern in that individual. There is no question that statistically, we want patients to look at be eating healthy. We find that their nutrition has a lot to do. When that person conceives, it's very important that if they have diabetes, we want that tuned up. We want their diabetes to be in ultimately tight control. If a person has hypertension, which is germane in our community, undiagnosed hypertension, every day we are finding that there's a genetic component of having hypertension. That is a big issue. Around the Great Lakes, thyroid disease has skyrocketed. We find that it has to do with environmental concerns, asthma and respiratory problems, and COVID. COVID has placed a curveball on everything that we have been doing. We have found that patients that have had COVID even without severe consequences, are having complications in pregnancy, premature deliveries, more miscarriages, etc. And of course, the support that a person has is also germane to helping that person get through and support them through the system of medical care and in a system that is quite foreign to them.
We're going to come back and talk about partner support and the goals and expectations in just a moment. I had one other question for you, Brother Gonzalez. Why are these disparities seemingly so great in the African American community, other persons of color, compared to other populations?
It is something that we're trying to figure out right now. There are what has risen to the top has been the stress component. We have looked at a lot of denominators with regard to how we feel in society. We find that our health, maternal morbidity, prematurity has been a great disparity in our community, and we have found that the common denominator, regardless of your socioeconomic standing, has been that stress component. How does one feel in one's community? How does one feel on their job? We have many stressors that we find that has risen to the top, and we are trying to address that at the present time. There's no question we have a history of having a great deal of misunderstanding, misinformation, and mistrust, which is definitely supported by some of the history of our race as it interfaces with the medical community. So I think that these are factors that we need to take into account.
Well, thanks so much. I think before we lost my mic, I was going through the introductions. I think one of our panelists didn't get their introduction. Michelle Theodore is a consultant at Healthy Start Coalition of Miami-Dade. Extensive experience working in community-based programs, using collaborative approaches, and has been a major catalyst for healthy living, and has been a strong leader and advocate for maternal, infant, and child health initiatives. So we'll hear from her in just a moment. But I'd like to toss to Simon from the March of Dimes. Can you tell us a little bit about the background of the collaboration of March of Dimes and what it's been doing in this space?
Thank you very much. So as folks have mentioned earlier, prematurity affects too many moms and babies and is significantly fueled by what we call our health equity gap and healthcare system today. So today the March of Dimes launched, or this week the March of Dimes launched our report card, which basically provides information on the health of moms and babies throughout the country. So based on our data, the U.S. earned E+ grade for preterm birth, with the preterm birth rate increasing to 10.5%. So just to put this into context, this is the worst preterm birth rate that the March of Dimes has ever recorded since we have been doing this report. Now more than ever, we're aware that there's a multitude of factors that are causing this to happen, right? So as Dr. mentioned earlier, there is structural racism that occurs, and within our communities, but also within our clinical systems, there are a plethora of challenges with regards to the health of the mother. So it's really important to recognize that the health of the mother or the birthing person influences the health of the infant. And so also we know that socioeconomic status plays a factor as well. So this is a dire thing we have happening right now. The United States is still one of the most dangerous developed nations to give birth, and that the magnitude of this infant health crisis is exemplified and illustrated throughout our entire report, which you can find on marchofdimes.org. So in general, just to give you a little bit more of a breakdown. So the preterm birth rate has increased for all races, right? And it's the worst rate that we've seen since 2007. And that 70%, 73% of all preterm births were late preterm births. So that means between the gestations of 34 and 36 weeks. This is about a 3% increase from the last report. Black women had an increase in their preterm birth rate, which went up from about 14.4% to 14.7%. And the second highest was for Native American and Alaskan Native or Indigenous women. And that went up from 11.6% to 12.3%. And so, and it continues to rise for other women of color. So in the Hispanic population, the preterm birth rate rose along with Asian American and Asian Pacific Islander women as well. So this is, and for white women, this is something that is going on across the board. And as the doctor mentioned earlier, there's a variety of different reasons why this is happening. So one thing is COVID, as he mentioned before. There are pre-existing health disparities that have been magnified. So for example, we learned during COVID, and we learned throughout our maternal and infant health work that some hospitals don't stratify by race and ethnicity. So if you're trying to actually help a disparity in a clinical system, if there's not a stratification within the data, if they don't know what people's races are and all those different things, that's going to make the inequities be persistent and even difficult to address. We know that there are some challenges with obstetric interventions that may contribute to a rise in preterm birth, and also that chronic health conditions such as hypertension, diabetes, chronic heart disease, these things put individuals at risk for pregnancy complications during pregnancy, but also in the postpartum year. And we found that the postpartum period is critical for birthing people and moms. And it's really important to pay attention to what's going on with that person in the postpartum period. So just as important as it is to know what's going on with the health of the baby, it is equally as important to know what's going on with the health of the birthing person or the mother before, during, and after pregnancy.
When I was on the OB-GYN rotation as a student, we spent a lot of time talking about twins, triplets, and those types, the individuals that had multiple potential births at being at high risk. Do you still see that, and do you still see that that older mothers are having more of these difficulties, or is it across the age range?
Yeah, so definitely when you have higher, when you have twins, et cetera, that does increase the possibility for more complications during birth and after birth. And then also we have found that, some folks are waiting longer or have children later on in life, and an increased maternal age does contribute to some pregnancy complications as well.
How would you define it, advanced maternal age?
Well, by definition, is 35.
35 weeks?
35 years of age. But I just, in terms of advanced maternal age, that definition has really come about by our ability to obtain a diagnosis. That has come about because, when we started to way back when be able to detect Down syndrome and different genetic abnormalities, the risk of getting the information could jeopardize the pregnancy. So that point, and we find that advanced maternal age is a situation where it should be individualized. I've been pushing to be able to see, whether the stress factors or there are other factors that a person can be, by definition, advanced maternal age, but be 34 or 33 years of age. But if you look at most of, just to be clear, if you look in any textbook, it'll be age 35.
Got it. To the Rakib family, I'd like to get a sense of your story. You come tonight to talk about your experiences. Can you share with us a little bit about your journey?
Sure. Thank you. My wife and I, we had our children at 23 weeks. It actually started out at the 22nd week when she had just returned from a flight to Atlanta. And when she came home, she was saying that, she could barely walk and these kind of things. And then when she went to the bathroom, she was like, oh no, we need to go to the hospital immediately. And when we got there, they said that she was already dilated by how much? How much was it?
3 centimeters.
3 centimeters. So, but at 22 weeks, the chance of survival was very, very low at that point. And they said in order for her to give our children the best opportunity, she had to be able to get to 23 weeks. So literally for a week, my wife did not use the bathroom or do anything and just really held down as tight as possible for an entire week to give our babies that chance of 23 weeks. And at 23 weeks exactly is when the labor began. So that experience in itself was just, we was thrust into a world that we never knew anything about until that point.
And to add to that, like Mukhtar said, we went into labor at 22 weeks, delivered at 23 weeks exactly. Twin A, Saeed, he weighed 1 pound 7 ounces. Nasir weighed 1 pound 3 ounces. And to kind of give you like an overview, we brought Saeed home 9 years ago on November 15th. Nasir unfortunately did pass away at 6 months and 27 days after a long, extensive NICU stay. They were born June 3rd, and their expected due date was September 30th. So it was a long roller coaster ride in the NICU, and I'm sure we'll speak more about it, but that is pretty much the beginning of our journey.
Yeah, but please tell us about your experience in the NICU and your interactions with the healthcare community.
Yeah, so in light of November being Prematurity Awareness Month, I was that mom that did not know what a NICU was. So when the doctors said that, we can they have a 10% chance of survival. They can either, pass in your arms if they are to be born at 22 weeks, or we can speak to a neonatologist. And I did not know what a neonatologist was, what they did, but I knew that if that would give them a fighting chance, then we needed to have that conversation. So a couple of days in, the anxiety is high, I'm very vulnerable, but, just a few days in, I knew that I couldn't stay in that state because, we had to advocate for our children. And so with that,
Dr. Mom was born, as we like to refer to her, because I think what happened at that point is that the maternal instincts kicked in, and she just really, really began to do as much research as possible on any terms, anything that was discussed in the hospital, even if the doctors weren't talking directly to us sometimes, which happened. She would be listening very closely and then finding out the information, and then later on asking those questions. So from that point, she really, really began to become our children's advocate and understanding everything possible that there was to understand from our standpoint.
Yeah.
I have a whole series of other questions to ask, but just in a point of privilege, I think, speaking for the panel, for all those who are listening, we want to extend our heartfelt thoughts and prayers for your loss and the experiences that your family has gone through, and the courage to come here and talk about that.
Thank you.
Yeah, thank you so much.
I don't know that if you haven't gone through that experience, I have not. I don't know that other persons in the world really can understand. But I appreciate your willingness to come and communicate with us.
Yes, thank you so much.
This experience, what types of effects have you noticed over the years, in terms of your family, in terms of yourselves, your relationship, your health?
I would say in that moment, there was a lot of anxiety and fear throughout our entire NICU stay. It's just kind of that fear of the unknown, but also keeping the faith and staying positive, speaking positivity on both children. Not tried to avoid bringing any negative energy, any tears. It was all smiles, when they looked up at us. So we did try to keep that energy. I would say long-term effects, certainly a lot of emotions, trauma, things that, we still deal with today as we grieve our son, as we answer random questions from our 9-year-old about his brother, where he is, if he's coming back. And with our other children, we have a 4-year-old daughter who says, Mommy, the sun is shining. Is that Nasir smiling at us? And so it kind of, because we've been doing this work and participating in these initiatives, our children see a lot of that. And the more and more they see that, they have questions. And so it's been, like I said, a roller coaster of emotions. Saeed, our twin, he has these bouts of, he's excited. He knows, what he's gone through. And then sometimes it makes him sad. Sometimes he does feel that, that void. But we try to kind of speak on the positive things and the outcomes that have come from this experience. And we hope to teach him more about that so that he can go out in the world and do great things as well.
And I think it really told me the true meaning of the quote from Rudyard Kipling, if you can meet with triumph and disaster and treat those two imposters just the same. Because of us having the success of one of our children making it out of the NICU, but at the same time, also losing a child in the NICU, we're able to look at the positive from both of those experiences, as well as the negatives, and actually allow any of those things to just make us better as parents. And, one of the things that we always do is, we advocate. We're big advocates for our children. I think that's one of the best things that we got from this experience. Even our children that were born full term, we're just big advocates, and we're looking out for them all the time in all aspects. It made us very aware of what's happening in their lives so that we stay really attuned to what's going on.
What communication, what advice would you have liked to have heard when you were in the NICU initially?
That's a really good question.
I think that our NICU experience, we had a lot of great support, especially from March of Dimes and social work, the counselor that was there. We had a lot of great advice, and I mean, some of the best advice we got was, pray. Make sure that you pray regularly. Do your research. So we did get a lot of the information that we were looking for. I'm not sure if I could say if there's something that we were missing.
I definitely will credit our NICU experience to the standards I have when entering any medical facility. So when I ask questions, they're very detailed, and then they want to know about my background, but it's because I asked some questions before. And I will, I recently told a doctor that one of my best experiences with a doctor are the ones that actually kind of map it out for you. So we actually had the privilege to meet with doctors who were willing to go over x-rays, go over different data about our children. And so they would map it out. Surgeons would take their pens and draw the entire procedure on their scrubs, just so that we could have that knowledge. And it definitely helped out tremendously.
Yeah, so Children's National Hospital definitely had great support team and great doctors and advocates there.
Do you think that those resources are universally available, or is it really focused on high level NICU intensive organizations?
I would say that the research that we kind of just did it on our own. You have to ask questions. Of course, it's a very sad and vulnerable time, depending on the circumstances. But it took me 3 days to kind of sit in a corner and cry and figure out where to even begin. But once I picked up a book and once I began to research and ask questions, that's when I felt more empowered. And I felt, it was received well. I can't say that even with my son passing, it brings, what do I want to say? I don't have any regrets, I will say, because I feel like, we did everything that we could do. And that self-taught education, those questions that you ask, putting your fear aside and, letting your parental instincts kick in, being observant of everything, documenting everything, and then asking questions. And so the resources are available. I know that we received a ton of resources from the March of Dimes, the booklets, the terminology of, these are words that may be used around you so that you don't feel like, the team is talking around you, but instead you're now a part of the team because you now understand. And so resources are available everywhere.
How would you access those resources if you were somewhere other than the Texas Children's Hospital in the Houston area, the National Hospital, as you described? If you're in a smaller community without quite the high level of technology, what do you have to do to get these resources?
The resources, I would say, depending on what's going on with your child, I'll use hydrocephalus, for example. Nasir, one of his diagnoses was hydrocephalus. And so when they said that while rounding, I would go to my phone, I would Google. Of course, you would have to look at a reliable resource, but that notebook that you carry around, take notes, look it up. I can't say that I can remember one credible source that I used in particular, but taking advantage of that time. And it's also important that parents know, what rights they have while they're in the hospital. So if you have questions or if you need a full care team meeting, as hard as they are to come by, you can certainly ask for that so that you can get a holistic view of what's going on with your child.
I would just add to a lot of the research that my wife was doing was from her phone. And I know that we all have phones these days, cell phones at our disposal. So a lot of the research she did was right there from her phone, sitting in that chair.
Yep. And I will add to that, we entered the NICU in 2013, and obviously technology has been well advanced since then. So now the March of Dimes has an app you can go to, whereas we received a book of pamphlets and papers that you would read, which is also, it was very helpful. But now for parents who don't want to leave their child's bedside, they can download the apps on their smartphones. They can look up March of Dimes and other community resources that are available to them.
Simon, how do we get more of these resources to individuals who may not be Dr. Mom and quite so self-advocating?
Yeah, I think it's really important to reiterate the fact that your instincts are important and necessary when your child is in the NICU. I am a parent of a preemie, and my son spent some time in the NICU as well. And it's important to follow your gut, follow your instincts. So if your gut is telling you to write this down, write it down. If you want to talk to a doctor, just like the previous couple said, talk to a doctor. Getting this information is critical when you're at that point within your journey. The March of Dimes has a plethora of resources available through our website. We also have an app as well where you can access our resources. And there's information out there. You have to make sure that it's credible, and that it speaks to you and that it speaks to your language. And when I say that, I mean that it's not very high level scientific jargon. If that's not something that you that resonates with you, find a credible resource that is more aligned with how you learn. When my son was in the NICU, my husband likes videos, so he was on YouTube more than I was. I was, looking at scientific literature. So it really does depend on your learning style and what is more amenable to you. But the March of Dimes has an amazing library of things that will really help folks that have preterm births or complications during pregnancy, and as well for a NICU stay.
Theodore, what are the resources that your community has identified that we're still lacking in terms of getting information out? I think we're trying to get her sound back.
Oh, I'm sorry. Great question. I forgot to hit the mute button to unmute myself. And so great question. So when we speak with the expertise of local organization, we are a local organization, I should say, based in Miami-Dade, Florida. And the Healthy Start Coalition serve as part of a statewide network of community-based organizations to reduce Florida's high infant mortality and improve the lives of pregnant women, infants, fathers, and families. And, you did ask that question, what are some of the resources that we provide? Well, we provide some core services that include care coordination, prenatal and parenting education, interconceptual care education, and some additional service that are available based on the resources of each county and available resources as well. Another thing that another type of resource that we have is that we conduct the ages and stages questionnaire on all infants enrolled in the Healthy Start program to determine whether the infants are meeting developmental milestone, and to provide education to parents on how to facilitate their baby's development. So when concerns are identified, infants are referred to local programs for in-depth evaluation and treatment if needed. We do know that many preterm infants need to stay in the neonatal intensive care units, and often for extended period of time and with varying prognosis. And so once they are discharged from the NICU, there are often ongoing challenges related to frequent visits to medical specialists or developmental concerns. So this takes a considerable emotional toll on new parents, and we've heard that from our panelists, and present a significant life stressors. So for families enrolled in Healthy Start, both locally and statewide, the Mothers and Babies program is offered, which is an evidence-based intervention designed to reduce parental stress and prevent depression. Also, in our county, mothers who are experiencing perinatal mood disorders are eligible to participate in the Moving Beyond Depression program, which is an evidence-based cognitive behavioral therapy model, which has been proven to reduce depression. We also have other local resources for, pregnant or postpartum women dealing with substance abuse issues. And of course, this is a little bit more intensive. So we provide more intensive care coordination, peer support services, and linkage to housing and employment resources.
How long are those resources available for?
So these resources are available from prenatal services until the infant reaches the age of 3.
Interesting. Question for you, and then again to the panel: what are the policies that we need to put in place to try to address these disparities, particularly those in individuals of color? Ms. Simon first, maybe.
So there's a variety of policies that are important to make sure that we begin to address the disparities in care. So we can start from the NICU perspective. So many families that go into the NICU, they have to figure out if they have paid paternity leave, if both parents do, if there are both parents in the picture, and what that's going to look like during your NICU stay. So it's really important that we have universal paid paternity leave here in the United States, which we don't right now. And so that's a critical piece. There are other aspects of preterm birth that are really important. So right now at the March Times, we're also looking at legislation for doulas to make sure that we can include doulas into the birthing process. Typically, when you have a preterm birth, your baby arrives earlier than you're expecting. And so having that support throughout your birthing process is critical. And then also, we know that the postpartum period is really an important factor during one's maternal health journey. And so we are advocating that in many communities across the United States, that Medicaid coverage is extended beyond just 60 days, but for an entire year. And so you may think, oh, well, if you have a premature birth, what does that have to do with postpartum coverage? But a mom that has premature birth or a birthing person that has a premature birth is going to need continual care and follow-up for about a year, right, after they deliver. So we are working on a variety of different initiatives. You can check out our hashtag Blanket Change initiative on the March Times website, and we're able to work across the aisle to make sure that we are advocating for moms and babies and birthing people to have healthy births before, during, and after.
And for Ms. Theodore, particularly in the Miami-Dade area, but what are the solutions that listeners can do to move beyond sort of the fear that we might have of prematurity?
So again, great question. I think there are many things that can be done to address the disparities in maternal child health. I think the first thing is to acknowledge that there are disparities that are, and that there is never a one size fits all approach. In order to address the disparities, I feel that you need to understand the root cause of the disparities. We can allow the data and the voices of the community to be the driving force of how we respond. Policies are great, but only work when they are applied equitably across the board. So if policies are in place, but only a portion of the folks that administer these policies follow through with what is contained in the policy, then I feel that the policy has already failed. More important than just policies is the need to have ongoing conversation in these communities to help change the mindset of the population and the medical providers in order to shift the perceptions, reactions, and processes to better address the needs of others.
In the Texas Medical Center, we've got the #2 children's hospital in the country, possibly the world, and in Texas Children's. But I certainly wonder if we see a disparity across geographies as you get further and further away from NICU support. When you get to other areas that have different socioeconomic, different ethnic breakdowns. Could either of you speak to that?
I can. So every couple of years, the March of Dimes puts out our maternal health, our Nowhere to Go maternity care desert report. And basically, it brings to light the complexities that are surrounding access to maternity care in the United States. And so there are disparities that exist beyond race. So race is a factor for some, but then also access to care, right? And so this maternity care desert report, we use the definition of counties that are without a hospital or without a birthing center to offer obstetric care, or without any obstetric providers. And so we've also included birthing centers into this description. And we found that there are over 146 thousand babies that are born in maternity care deserts throughout in 2022. We also know that there are over 2 million women that live in these maternity care deserts, and that counties with low access to telehealth are about 30% more likely to also be maternity care deserts. And we talk about including Medicaid doula benefits into policy structures because that's going to be an integral part as well. So access to care is a key component, but also access to quality care, right? So what does quality care look like when a birthing person or a woman is pregnant? And is that quality sustainable throughout, her entire, or that person's entire pregnancy cycle and beyond? So those are two things that vary greatly throughout the United States. You can check out our website, which also has our maternity care desert report that was launched earlier this year, and it'll give you more information. I was very surprised. I live right outside of DC, and DC is a maternity care desert as well. So it sometimes occurs in places where you may not think.
Excellent.
I definitely agree with that. I wanted to weigh in just for a minute that the access to care, there are so many different systems in the United States. I was often surprised that when working down on the coast outside of New Orleans, that the politics and the access to care structure changes from state to state. You can be less than an hour, but the supports and the things that are happening in Mississippi are so much different than Louisiana, and vice versa on the Alabama side. But just a few comments.
Are there opportunities to advocate with our political leaders around funding for this type of healthcare?
Yeah, I'd like to comment on that. So, I'd like to say that for Alpha Phi Alpha, we have been promoting and been involved with prematurity, as mentioned, since the 1980s, and we have helped to raise millions of dollars for support for the March of Dimes and the work that's done in addressing prematurity. But also, as a fraternity, we typically do what's called Alpha on the Hill, and it's an opportunity for us when our various states are in legislation to go up and lobby for different rules, different things that are typically impacting brown and black communities. For example, this topic. So we believe there's opportunity for us to go and lobby to bring on our agenda during Alpha on the Hill times, or when state legislation is in office, is in session, to really campaign and promote that more public awareness, more public engagement, more education and training. We talked about tonight how on this webinar, the misunderstanding and how there are some resources out there, or even when there are what was mentioned as these deserts where there's very little care there. So I think there's opportunities from an Alpha Phi Alpha perspective that we can lobby. We can during Alpha on the Hills really bring this to the forefront and make this an agenda item for our state legislations. I think we can do that throughout the fraternity all over the country.
Thank you so much. From the Rakib family, can you give us a sort of a summation of things that you would like the audience to take, use going forward in terms of things to do?
Yes. The first thing that I think is very important for the audience to do is to be an advocate for your child. Educate yourself. That's the most basic thing that you can do in this process, is to really educate yourself and seek that information that will help you be a better advocate for your child.
Mecca, is there anything else that you wanted to
Yeah. I would say definitely, like Mukhtar said, educate yourself, ask a lot of questions, be fearless, be your child's biggest advocate. In the NICU alone, just being, if you can, we do have working parents who aren't able to be at the bedside. Mukhtar did have to go back to work, and so I was juggling between both rooms for most of the day for a little bit of time. But ask questions. It's called care. So when you're at your child's bedside and it's time to get temperature checks, diaper changes, be a part of that. Be a part of rounds. Stay connected with people. Don't shut down. Make sure you have someone that you can lean on. If you're a couple that's there doing it together, rely on your partner, be there for your partner, give them some grace, allow them to feel what they feel, but get through it, and be observant of everything. So if you see something that happens overnight, make sure you bring it up the next day to the doctor or to the nurse, because most times more about the events of what takes place in that NICU, whether it's a single room or if you're in a pod. You're consistently looking at your child. Just be observant. If you see any changes, make those aware. Build a community if you have an opportunity to do so, and just keep the faith.
And last but definitely not least, trust your instincts.
Yep.
Trust your instincts. When you hear something or you feel it, make sure you speak up and trust your instincts, because a lot of times it's right on point.
Outstanding. Ms. Simon, from the March of Dimes perspective.
So I think that when we talk about prematurity awareness, there's a lot of gloom and doom. There's a lot of fear, sadness, uncertainty, all of that. I think when a family is going through this experience, or if you're someone on this discussion, or an audience person who's thinking about getting pregnant, it's important to realize that there are valleys and there are hills and there are peaks and there are mountains, and that there are some positive stories that come out of folks that do have a premature birth, and that it's important to stay informed. It's important to allow yourself the time and space and the grace to do what you need for yourself, for your family, and for your child. And then lastly, for those on this audience who are support people, if you're not the person who's actually giving birth, then it's really important that you be the advocate, right, for the birthing person and the mom and the infant. The support of a partner or a friend or folks that aren't giving birth is paramount to the health and wellness of the birthing person or the mom and the infant.
Fantastic. From the perspective of Miami-Dade, Ms. Theodore.
Yeah, there's one thing that I wanted to add in terms of support that we provide with the universal risk screening. It is a requirement that we have for prenatal providers and hospitals to assess pregnant women and infants who are born premature, and where we can get this information and provide more support to these individuals. And I what I would say on the side of the providers is, well, first of all, I echo what everyone have said previously, but I would say that we need to be able to understand, because Miami-Dade is very culturally diverse. So understand the culture and be sure that we follow up. It's not enough that we are just providing resources or brochures or to the family, but it's important for us to follow up with the parent to make sure that they're okay, to make sure that the place that we've sent them to actually is still active. And we do pride ourselves, Healthy Start Coalition pride ourselves in doing this well and following up with all of our clients.
Fantastic. Brother Rodriguez?
I appreciate the perspective of this panel. And in medicine and being an academician, I see so many toxicities that we're trying to address in a positive way. But the voices and the interdisciplinary respect that we need to have, it crosses all lines, whether you're a physician or whether you're any type of provider, mid-level, etc. It's a multifactorial problem, and it's going to take a collective, respectful effort to be on board to move forward to make a difference. So I applaud the work of this panel.
And thank you for your work. Brother Kelly, any final comments? Sound. Unmute, Brother Kelly.
I apologize for that not coming off mute, but men of Alpha Phi Alpha have always been at the forefront of issues and that has plagued the Black and Brown community. We will continue to strive to do that. We will continue to seek three goals: share knowledge, change attitudes, and provide skills through self-empowerment and self-esteem and training education. As Alpha men, we feel this is what we are charged to do. Through our fraternity, we have various initiatives, health initiatives, to include our Surgeon General Health Initiative. Many of our regions and brothers around the world have established also health initiatives to continue to bring about this education and training. So as we've done here tonight to create this webinar, to really have this candid discussion regarding the gaps, we'll continue to do that moving forward. Thank you.
Well, thank you so much. Thank you to each of you. People often ask, why did I go into geriatric medicine? And I often tell them it's because my older patients have the best stories. And one of the things that I have come to learn and is reinforced in my own practice every day is that we in the medical community don't spend enough time listening to patients. We think that we do. We talk at patients all the time. We don't listen to them enough and learn from them. And each and every one of you has worked to try to address that today. I'd like to bring forth thanks to our General President, Brother Lonzer, and to our Surgeon General, Brother Sterling, that you heard from before. I'd like to again remind everyone that our next presentation is going to be December the 8th. It's going to be speaking on Black health in America and Alpha Phi Alpha Surgeon General Initiative, and we are going to feature Brother President, General President Willis Lonzer III. I'd like to take at the end, a point of personal privilege to recognize the anniversaries of Alpha Eta Lambda as it's going through its 95th year, and my own initiating chapter of Rho Iota with its 33rd anniversary this week. Again, thank each of you. This only happens because individuals on the panel have an opportunity to come together, individuals in the audience come together to have this conversation. We'd love to continue it. Please let us know in the chat other ideas that you have for webinars, other things that you'd like to hear from as we continue to work on this dialogue. I speak to you from the Family Health and Education Committee, but most importantly, I'd like to thank each and every one of you for your time this evening. Good night.